Okay, let's keep moving then. So nephrolithiasis is a part of nephrology that is also complex. We should be adept at evaluating and managing nephrolithiasis. There is no such thing as mineral metabolism clinic anywhere but a handful of places, okay? Meaning, even though things are sourced to mineral metabolism here for kidney stones, in the real world, this is in the wheelhouse of a nephrologist and a urologist, okay? Urologists have varying degrees of comfort in medically managing kidney stones. Many times you'll get these referrals from urology to evaluate and manage the recurrent kidney stones. They're the plumbers, and then we'll be the technicians that try to reduce the frequency of stone events. Okay, so pay attention. There's no such thing as mineral metabolism. This is you. All right, what's the background that you need to know? Well, there are multiple risk factors of kidney stones. Male gender is a kidney stone risk. That being said, in time, there has been clearly an increase in the frequency of kidney stones amongst females as well. So this previous significant male predilection is becoming less and less prominent. Females are getting kidney stones more often. Perhaps that has to do with the rising rates of obesity. Caucasians have a higher rate of kidney stones than African Americans, which is not well understood, but it is true that Caucasians have more kidney stones than African Americans, quite noticeably so. It's not subtle. Age is a risk factor. In general, this is something that middle-aged individuals manifest. However, there's another spike that happens in in this kind of the 20s, especially in females. There is a situation in which hypercalciuria is manifest in pregnancy. So some of this may be related to, the fertility period of females. We'll talk about that, I think. Well, I'll just highlight it now just in case. So pregnancy seems to have a scenario in which calcitriol levels increase, and that may make sense, right? If I'm trying to create a skeleton inside my, placenta, right, or inside the uterus, I need to absorb more calcium from the diet, right? If I don't, well, that baby's going to get the calcium it needs. It's going to come from my bone. So there's an increase in calcium absorption from the gut that happens during pregnancy. There's also urinary stasis that occurs through the effect of progesterone dilating smooth muscle. And so urinary stasis plus hypercalciuria can predispose to kidney stones. So this is something that does happen in the peripartum period as well. Okay. Interestingly, you'll see PTH levels that are somewhat suppressed when in the pregnant female, because again, they have this relative calcitriol excess. It seems to come from the placenta. There are some studies that suggest there's an increase in 1-alpha hydroxylase activity in the kidneys, but again, there is clearly an increase in calcitriol production. PTHs tend to go down. You'll also sometimes see PTHRP levels that go up during the course of pregnancy. Breast tissue is a source of PTHRP production. And so you can see these mild elevations in PTHRP during the pregnancy, also causing a tendency to a little bit of hypercalciuria. Okay. All right. So let's move on to diet. High protein diet, high salt diet, low fluid intake are predisposing factors. We'll talk about salt. Well, we'll talk about it now. Sodium excretion rates and calcium excretion rates correlate 1 to 1. And it makes sense because if we think about it, remember again, proximal tubular handling of salt and other solutes, including calcium, is influenced by circulating volume. If I have high salt diet, my circulating volume is expanded. And then my reabsorption of salt and other solutes, including calcium, is going to be diminished, right? Therefore, my calcium in my urine is going to tend to be high, right? So hypercalciuria is a common feature of high salt diet, okay? High protein diet has a less clear mechanism of how high protein diet cause hypercalciuria. Some investigators have hypothesized that particularly aromatic amino acids um, that are present can actually uh, activate the calcium sensing receptor. That's a hypothesis. I haven't seen strong data in support of that hypothesis. And so calciuria or hypercalciuria could potentially be caused by that. When I bind the calcium sensing receptor, right, let me use a different color. I have calcium sensing receptor throughout the nephron, proximal tubule. It's most well spelt out in the thick ascending limb. We talked about that as one of the Bartter syndromes. Here we are in the thick ascending limb. I have the calcium sensing receptor. There's a Bartter syndrome in which calcium sensing receptor activation inhibits these apical transporters and then causes a salt wasting. Again, calcium sensing receptor, if you bind it with calcium or with some agonist of the calcium sensing receptor, such as even cinacalcet. Cinacalcet can theoretically worsen hypercalciuria. Sometimes we medically manage a primary hyperparathyroidism when the surgeon goes in and sees four-gland hyperplasia, and so you can't just take out well, you could try and do a subtotal parathyroidectomy, but they may still have hyperparathyroidism, or they can't find the adenoma. We sometimes treat those patients medically to suppress the PTH production. However, one potential downside of giving calcimimetics is activating the calcium sensing receptor, causing some tendency to sodium wastage, which is mild, but enhancing urinary calcium excretion rates. That can happen. I have calcium sensing receptor not just in the thick ascending limb, but also in the proximal tubule, as well as more distal segments. It's been shown to be present as well. If I bind the calcium sensing receptor with an agonist like calcium, that will inhibit the reabsorption of calcium in that nephron segment, enhancing calciuria. Okay? All right. So again, protein. Oh, the other mechanism whereby high protein diet may cause a hypercalciuria. High protein diet, particularly animal proteins, is an acid load. Acid loading would potentially liberate calcium phosphate buffers from the bone. Calcium phosphate or hydroxyapatite, which is calcium phosphate, is a potential buffer. When you get acidotic or chronic acidosis, you have problems with bone mineralization, right? If you see a child with an RTA, you'll see a slow rate of growth, right? You look at their growth curve, it's falling off the growth curve, and then you give them base, and then suddenly they can start mineralizing the skeleton, and then their growth curve has an inflection point. Okay, just highlighting how again your bone is a buffer. Okay, and so acid loading could theoretically cause hypercalciuria through simply bone predisposing to be bone demineralization. Hot climates, strenuous occupation. So often you'll ask your patient, are you an air conditioner repairman? Someone who's sweating a lot is essentially going to have small urine volumes. So that's what you're looking for. People who are sweating or in hot climates, you're having loss of water through non-renal routes, and then your urine volume drops. Urine volume drops, predisposes to kidney stones. Oh, I talked about pregnancy. Here we go. Yeah, I haven't said much else here. So medullary sponge kidney is a risk factor for kidney stones. Now, the literature has varied a bit in what type of kidney stones. Uh, Classically, people have described calcium phosphate stones as more common in medullary sponge kidney. However, I've seen a fairly rigorous study done in which it was fairly carefully phenotyped patients with clear medullary sponge kidney. The most common stone in a series out of University of Chicago, another prominent center for kidney stone research, was calcium oxalate stones. Even though the textbook says calcium phosphate is more common, perhaps because of the correlation between medullary sponge kidney and renal tubular acidosis and incomplete renal tubular acidosis, uh, the uh, more common stone, in my view, based on that UFC literature, is a calcium oxalate stone. Okay. Medullary sponge kidney does seem to have commonly hypercalciuria, though not always. What is medullary sponge kidney? I guess we need to talk about what it is. It is a developmental disorder, not clearly heritable, okay, in which the ducts, the of Bellini, right, in the distal nephron, all of these collecting ducts are converging into these larger ducts before they empty into the renal papilla and then into the urinary calyces, right? Do I need to draw that picture here? So you have all these nephrons, right? And they're dumping into, again, larger and larger ducts, right? And all of these are converging into these ducts that are at these renal papillae. You'll have these ducts that are forming, right? And then here's where the renal calyces are that collect that initial urine, converge, and form that renal pelvis, and then ureter and out to the bladder. Okay, so medullary sponge kidney is a developmental disorder in which these ducts are dilated. Okay, so you can expect then that tubular flow rates, if the lumen is larger, is going to be slower, right? If I have tubular flow rates that are slower, then precipitates can form more easily, right? Kidney stones are in central pathogenesis are I have a urine, right, that has a high salt content. Often it's the calcium content that is calcium salts that are maladaptive, right? I have calcium oxalate, phosphate, right? I have a urine that is super saturated. We'll talk about that in a bit on another day, not today. That means that this solution is tending to spontaneously form precipitate. So what is inhibiting it from forming precipitate? Well, if urine is moving, right? If I'm mixing a solution, I dissolve more easily, right? But if I stop mixing that solution, then precipitates form. So that's one factor. There are multiple other factors. I have inhibitors of urolithiasis. The citrate, for instance, solubilizes the calcium instead of it binding with oxalate and phosphate. I have TAMS horseville protein or other mucopolysaccharides that inhibit calcium stone formation. If you know if you ever made, let's say, rock candy, if you've ever formed rock candy, one way to start the process is you put in a little bit of a nucleus for stone formation, right? I put in a tiny crystal, and then the crystal rapidly starts to grow from there, or a pipe cleaner, things that are irregular surfaces that these crystalline structures can grab onto and start forming. Or in some cases, it is bacterial um, uh, what's the word? Bacterial debris, right? Dead bacterial cell bodies that are forming these nuclei for further stone formation. Or in many cases, it's going to be the what are called Randall's plaques and plugs. Okay. Randall's plaques and plugs are areas of calcification, usually calcium phosphate, that form in the hairpin of the loop of Henle. That's Randall's plaques. or they can be calcium phosphate forming in these ducts called Randall's plugs. Okay. These are again, starting points or these nuclei, right, for further stone formation. Okay. Often these are present and serve as that initiating event for calcium stone formation. Okay. These potentially erode through the papilla and out into the urine, forming kidney stones. Okay. These are actually on the basolateral surface of the epithelium in the loop of Henle, Randall's plaques. Okay. Um, all right. So medications can be predisposing factors. A classic one are carbonic anhydrase inhibitors. So topiramate is used for migraine prophylaxis or for seizures. I've had patients who are on seizure medicines with kidney stones or they're on acetazolamide or Topamax for treating normal pressure hydrocephalus, and then develop as a side effect kidney stones. Or they're using these drugs for weight loss, another scenario in which you might see these. And then there can be rarely drugs that actually precipitate in the urine, including certain HIV medications. Indinavir is very rarely used, but there are theoretically others that can cause it very rarely. Okay. 24-hour urine chemistries, again, here we're still in the risk factors for kidney stones, can sometimes tell you what are these risk factors. Now, even though you have these various parameters that are present, uh, these two are not, again, binary data. If you have a urine volume that's 2.1 versus 1.9, there's a meaningful difference between those two patients. So don't think of these really as thresholds, but think of these as sort of ballparks of where kidney stone risk starts to rise. Let me re-emphasize it here. If I have a patient who has a calcium oxalate stone former and their urine calcium is 180, I will still target that as a potential way to lower their kidney stone risk. You don't say, oh, they're less than 200 for a female, 250 for a male. They're good. We shouldn't use thiazide diuretics in those patients or salt restriction. So there's a graded effect. If you already are a kidney stone former, if you can keep lowering that urine calcium down to the low 100s, you have greater graded effects on kidney stone risk in that patient. Okay. Again, there are multiple factors. One way that we summarize all of this multiplicity of factors in predicting a stone risk is through calculating a supersaturation. Okay. I've alluded to this. Remember again, your urine in general is supersaturated for calcium oxalate. Yours and mine too. Okay. What does that mean? Saturated means a solution contains all it can of the calcium oxalate in solution, for instance, right? And so this would be the case. Let's say if you took a uh, calcium oxalate stone and you put it in some urine in a cup and you let it sit for a while, eventually this stone will dissolve until the calcium oxalate in the urine is soluble and has reached the solubility point of this urine. Now, again, urine in you and I has more than let's call it the solubility or the resting solubility of calcium oxalate many times. Okay. And so we express that um, concentration. It's not truly concentration, it's actually quote unquote activity. The calcium oxalate or calcium phosphate activity is compared to the solubility. Activity is a term that takes into account non-idealized solutions when I have ionic species that interact with water and other salts, influencing their solubility. Okay, that's activity takes into account the effect of this charged feature of the species of interest. Okay, so again, it compares the, let's just use concentration of calcium oxalate over the solubility of calcium oxalate. Okay, and so when I have a supersaturation that's greater than 1, it implies that, yes, this is supersaturated. Okay. Many times people, you and I, have supersaturations that are 2 right now. We should be forming kidney stones. Okay. But we don't because we have tubular flow rates and some of these inhibitors of stone formation in our urine. Okay. And we don't have the nuclei. We don't have the Randall's plaques and plugs yet. Okay. Or the bacteria in our urine that are predisposing to these stones. Okay. Now, you can express supersaturation in 2 major ways. You cannot necessarily compare a gosh, I'm blanking on their name, Litholink supersaturation to the supersaturation that you get from our lab here in the Mineral Metabolism Center. Okay, supersaturations look at the normal range. We would, for instance, in our lab, say supersaturation greater than 2 for calcium oxalate. They have supersaturations for struvite is going to be something like greater than 70. Okay, that's considered abnormal. But for calcium oxalate stones, in our lab, it says supersaturation greater than 2 is abnormal. What does that mean? Well, it says that compared to normals, who often have supersaturations that are, in the low 2s or high 1s, right? We don't form kidney stones, but having a supersaturation greater than 2 is a risk factor for stones. Okay, so it's sort of compared to normals, a supersaturation greater than 2 is abnormal. Compared to non-stone formers, greater than 2 is abnormal. Okay, then there's another way that it's described, right? There's another way that says, well, Litholink's lab is a relative supersaturation where they express, no, actually, they just use supersaturation of 6 or more as being, actually, we express ours as a relative supersaturation, excuse me. R2 is a relative supersaturation. It's compared to normals, saturation compared to normals, okay? 2 times higher than the supersaturation of normal is considered abnormal, okay? But in Litholink, if you have numbers in the 5 to 6 range, that's considered abnormal in the Litholink lab, okay? So again, relative supersaturation versus supersaturation, you'll need to, again, pay attention to when you look at an individual lab's data. Okay? All right. I may end there. Let me just see if there's something that is, yeah, I'll go through these individual stone risk factors next time as I segue over to the pathogenesis of individual stones. I can talk about pH and, for instance, ammonium excretion rates when I'm talking about things like struvite and phosphate stones. Okay? Questions?